Hey everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in health IT. And we're here at the SAS Innovate conference, and our guests are Dr. Keith Morris. He's professor of pediatrics and medical director of clinical informatics at Stanford Children's Health, and Dr. Armando Bedoya. He's chief analytics and medical informatics officer at Duke Health. Welcome, guys.
Thanks for having us.
Yeah, excited for the discussion. We just came out of a really interesting session, so I want to highlight some of those key insights. But, maybe you could start. Tell us a little bit about yourself and your organization.
Sure, happy to. So, Keith Morse, I'm one of our medical directors for clinical informatics. I lead our TDAP organization, which is our deployed AI group within our children's hospital. Our children's hospital is Stanford Children's, is part of the broader Stanford ecosystem, so we share learnings, resources with our adult colleagues, with our School of Medicine and our university at large, which I think is going to be relevant to the discussion today, because a lot of the sort of innovation and insight that we benefit from is a product of the university ecosystem in which we exist.
Very interesting. Armando, how about yourself and Duke Health?
So I'm a pulmonary critical care physician at Duke. I've been there now for about 12 years, and I serve as our chief analytics and medical informatics officer. I oversee our analytics center of excellence in our information technology shop, and then as well as our medical informatics physician champions who work in clinical informatics. Duke is similar to Stanford. We have our health system, we have our School of Medicine, as well as our university. Within Duke, we have 3 hospitals: Duke University Hospital, which is our main academic medical center. We have Duke Regional Hospital, which is another community-based facility in Durham. And then we have Duke Raleigh Hospital, which is a community-based hospital in Raleigh, the capital.
Awesome. So talk to us about how analytics has evolved in your organization when it comes to who is interested in the analytics and not just who, but maybe how they're being used.
Great question. So I had the privilege of being a very young physician when we were still on paper.
Okay.
And going through the transition of electronic health records and this monstrous amount of data that got created, as well as financial, operations, clinical. So essentially everybody now is interested in using that type of data. We have mounds and mounds of this over the past. We've had our electronic health record now for about 10 years after it's been fully installed. And so there are lots of individuals who are interested, trying to understand, how many patients do I see at this time period? What type of blend of those types of patients? What type of care are we providing? Some of the financial components, the operations. How am I moving patients through a clinic? How many surgeries are we doing? So it runs the gambit from clinical folk, operations, finance, supply management. All of these individuals are very much interested in using analytics now to drive their decisions.
It might be the problem is there's too many options. Yeah. What else would you add? And maybe let's expand it also to the data that you need or want. How has that continued to evolve?
Yeah, definitely. So like Armando, we have EHR data that is interesting to every walk of life within our organization. We have taken a federated data approach where we have developed data reporting infrastructure that can be pushed out to our data champions. So folks within specific components of the organization who are trained in developing reports that are relevant to their day-to-day. Because what we know is sort of the ratio of people who want the data to those who are analysts within the data warehouse is not well balanced. And so we have way more people who want the data. The other struggle is there's this sort of phenomenon of this data rabbit hole where I've never ever heard somebody say, "Thanks so much, that completely answers my question. No more analytics needs here." Every single project is, that's wonderful, what about one more thing? And so as we try to figure out how we sort of meet this sort of insatiable appetite for analysis, our approach has been this federated model that allows people to dive really as deep as they want.
Interesting. That's part of that evolution of who is using the data too, I think.
The types of data, I think, and Keith is completely right. There's a voracious appetite for not just electronic health record data, but data that exists outside of the electronic health record, and the use of data, particularly in clinical care. When I think about it, when I see you in a clinic, I see you maybe for 30 minutes, 15 minutes, 20 minutes, maybe around that time period, once a year, maybe a little bit more if you're sick. When in reality, you go through your entire life outside of any clinical care, and you are exposed to everything. There is air quality, where you live, your home, type of food you eat. All this information kind of gets gathered in different locations, your watch, your iPhone, things like that. And people are asking, can we bring that information in and combine it with clinical data to improve patient care? So there's a lot of these different modalities of data that people are interested in, and AI has really driven that desire to use that type of data.
So talk about that more. AI driving the change. Is it the change in the types of data or in just the desire to have the data or access to the data? Or
I think it's both. I think it's all three, frankly, the way you're framing it. When we look back a few years ago, we just talked about, like I said, the clinical electronic health record. That was it. Maybe some finance and operations data, payers and things, claims data. But now, as there is the Internet of Things, census data, government data, environmental data, there is so much more that people are realizing they could bring in to augment these AI tools to really make enriched, augmented AI based on all this new information. So you need to be able to have that data, you need to be able to bring it in, you need to be able to scale it, you need to be able to have access to it, to use it for AI tools.
interesting.
Another thing that we're seeing is notes data has historically been underutilized in a lot of our projects. It's something that we have, and we've had NLP capabilities, but it's usually sort of one-off. Like if you want a tool that can tell you, what day of illness is somebody when they present to the ER, you would have to build that specifically. What we have now is large language models can more or less do that for any application. So if we can set up a pipeline of connecting notes to large language models, we then sort of open up this field of opportunities to pull whatever necessary elements out of that free text that has been historically pretty painful to get at.
Interesting. That goes to a point of something you said in your session here at SAS Innovate. You said that healthcare has a workflow proliferation problem, which I was like beautifully said. Talk to us about what that means, and then how does it relate to what I think you just talked about with generative AI and AI in general?
Yeah, definitely. So problem there doesn't mean that anybody's doing anything wrong. Problem in the sense of it makes our life on the analytics side very painful. You think about this in terms of, so for example, pediatric oncology. So we have seen immense strides in treatments of pediatric cancers over the last 40 years because we implement clinical trials in our hospitals. So patients who are part of these clinical trials, one arm has one treatment protocol, the other arm has a different treatment protocol. Those are two separate workflows for treating the same cancer. And those evolve every couple of years, and this is just the field of oncology. So you can imagine if we are trying to build analytics tools that sort of inject into the right part of a workflow, and the workflow is multiplying, evolving, contracting, it is really hard, even for us in our own organization, to sort of pin it down, like understanding it once, and then you go away for 6 months and you come back and it's different. And so when we try to develop tools that are really refined for these specific use cases, the proliferation of them means that we spend a lot of time chasing our tails.
It is really interesting to think about this proliferation, because we saw the proliferation of communication tools, but guess what we did? We consolidated, right? We said, okay, fine, we don't need 7, we can just get away with 2, and they built more features. But with analytics, you often can't, right? Like, you're like, okay, I built 100. I can't just say, compile them down, let's just do 5 now. Like, that doesn't really work. I think that's the problem you're describing, right?
Yeah. I think part of the issue, though, is for the life cycle of developing an AI tool, developing, validating, implementing is often so long that things may have evolved from the beginning to the end of the project, and so you don't end up with as sweet of a solution as you've hoped. In terms of the proliferation of sort of other analytics tools, I mean, one of the approaches that I think has been sort of helpful for us is sort of support. Like, very few end users can use the tools on their own, and it helps nudge people towards a more modern infrastructure or whatever sort of current reporting system is. If there's less support for the one that they may be most comfortable with, sort of helps nudge people a little bit.
Oh, that's interesting. Armando, what would you add to that? And, I think you also talked about governance in the session, which I think is a key element here, because, you still have to support everything that gets implemented. Yep. So how do you approach governance of these?
So at Duke, we created an organization called the Algorithm-Based Clinical Decision Support. It's a mouthful, but we can shorten that down to ABCDS.
Okay.
What we found was a couple of things. These types of projects that come forward in the clinical space can be very large. Mm-hmm. They have lots of technical debt. If it breaks at 2 a.m, sometimes you got to fix it at 2 a.m, depending on what it's being used for. And we realized very quickly that we needed to bring in other people to help us understand. I always say, clinically, I was never trained in AI. I was never trained in data science. I was never trained to understand this. My clinical background in medical school never prepared me for this. Mm-hmm. But there are people who understand this space. And what we've done at Duke is combined our subject matter expertise in the clinical space, the people who understand the problem, the workflows, then technology folks in our information technology to understand some of the data and the data and how we can deliver some of the technology stacks, and then data science. These data scientists, and then we bring in some of the legal and the regulatory folks, and we really created this group of individuals that can sit down, look across a model life cycle and say, okay, what are the things we know are best practices when we're talking about it's just being put in production versus to we're going to put it and people are actually going to be using it in a small pilot versus this thing's been on for 3 years. Okay, how do we look at it? Do we need to change it? How is it the care it's being used in is changing over time? So that's been our approach. We've taken what's called the people by bringing individuals from the university side, as well as our health system, information technology, data scientists, legal, regulatory, understand the process, and then combine that with the technology that we have available to us to really govern the space.
Interesting. Well, and one of the things I love about Gen AI is it's caused this explosion of creativity. Everyone wants to solve a new problem because now they see the potential, right? Yeah. But I think from your perspective, it's probably like, in some ways, like, oh, dang, we're going to get a lot of requests does it go through that same committee, or how do you approach this kind of explosion of desire to have new tools implemented for their organization, for their department, for their disease? There's a lot of them.
So we want all these tools to be able to, if they work and you can show us they work, we want these tools to be able to, because we know that they have potential. They know they can be used.
They can save lives.
They can save lives. They can make my life easier. They can help our operations. We can be more efficient. We can be more productive. So we have tailored our process to take a risk-based approach when it comes to it. We might view a AI tool that needs to be being used in a critical state be very different than, well, it's just going to look at this operational thing that doesn't really affect clinical care that much. So that allows us to streamline our process to allow to really focus the resources we need on the models that may be at higher risk, but might be still very useful.
Yeah. And what else would you add, Keith? And we kind of talked about new ones, but you even mentioned, how do you evaluate the old ones? Should we keep doing it, or is this even effective once it's implemented?
Yeah. This is kind of your earlier comment about the proliferation of potential use cases around Gen AI. So we, about 3 months ago, released our PHI compliant chatbot within our organization. So ChatGPT, but you can put patient data into it because it's been our secure environment. And we were a little worried that it was gonna fail from all the demand, and that's actually not what we saw. And the reason is that most people either don't know at all what Gen AI can do, or how Gen AI can make their life better, their work life better, is new for everybody. And so we are short on both education and also experience. So education in terms of what is an LLM, what are the basics of prompting, but also experience, because I don't know where in our organization these tools will be helpful, nor do the people who they potentially could help know yet. And so we're sort of waiting until either folks in our organization have enough time to play around with them, stew over them, try things out, or people come to conferences and they learn from their peer communities about how these things can be useful. And so it just being available, we've found so far isn't enough to have people figure out exactly how it can be used. I suspect a year from now, we will have the sort of situation you're describing, but just being able to put things in is not enough so far.
Interesting. What's your perspective on that? He's kind of talking about clinician readiness for these AI solutions. Are they ready, or are they concerned? And I'm sure there's a gambit, but what do you see?
I think clinicians are concerned about this. So I'm a critical care doctor. When I prescribe a medication, when I do a diagnostic or a therapeutic or a procedure, I understand the risks and benefits that I can explain to a patient. With AI tools, it's so new, and so people need to understand, want to have an understanding a little bit of how it works, what are the benefits, what's the risks behind these things. So we can train people on that. And that's what we've attempted to do at Duke, is to be able to provide that information. Mm-hmm. Our innovation group came up with this great idea about a nutrition label. Okay. Basically putting it on and saying, this is what the model does, this is how it was trained, these are some of the characteristics and features, these are the things of what it was meant to do, which allows you to say, well, am I using it for what it was meant to do? And then also it talks about, the risks behind it. So that type of information is incredibly useful. I can take that as a clinician and then apply that to the patient when I use that type of model. So do I think clinicians are uniformly ready right now? Mm-hmm. No, I think there needs to be education and training. The way we do probably medical school might be different now, with applying more data science concepts in there, understanding risk and prediction. In general, to me, is going to be an important part of training as we move forward.
Interesting. Well, and ONC is kind of enforcing this nutrition label concept. I don't know who stole from who or who shared with who. They stole from us. I know that part. It's all sharing. That's good. No, I think that's interesting. Well, let's wrap up with a really easy topic. How do you approach things like bias and ethics in the analytics and AI solutions that you're doing? I love when people talk about AI and bias and in analytics and bias. It's like, well, sometimes bias is actually good because it actually means that population has different needs than this population. But it's complicated, right? So what would you take on this really simple topic? So obviously sarcastic.
We've taken a couple of approaches with this. Within our AI governance, it's embedded in every single checkpoint that we have. Have you looked at it? Have you thought about it? Where is there inherent bias in, for example, the data, or how a person might apply that model to the clinical workflow? In monitoring, we make sure people have to do specific subgroup analysis, and this is just small bits and examples. We have in our Duke Health, our AI health organization has specifically hired individuals, ethicists, to be able to assist us in thinking about how our governance can look at this and make sure that we are providing equal and just care to our patients.
Interesting. How about yourself? I know you in your session, you gave a thought and said, this is important, but this is hard.
Yeah, it is hard. And I think sometimes we get tripped up, particularly now as it's sort of new for everybody, with bias being this subtle, difficult thing where you need a stats PhD in order to pull apart. We, I think right now are focusing on bias that is visible from the moon. And what I mean by that is we are a pediatric organization, pediatric and obstetrics, and most algorithms that are sort of approved don't include strong representation from those populations. And so when we think about equity, our first priority is sort of the equity of our patient population, which is a minority population, sort of on the spectrum of ages. What we're trying to avoid is the sort of scenario that we have with pharmaceuticals and approvals and off-label use in pediatrics. So they did a study, about 28% of pediatric visits involve prescription of a medication that is off-label, meaning it was never approved for a kid, but years ago we just sort of took risks and started giving it to kids and they didn't die, and so we keep giving it to them. We don't want that in pediatric AI. So sort of having this idea that equity comes from being as rigorous on our patients as we would expect on the broader population, so that hopefully we can sort of bake that into the AI culture. And then one final point is pediatrics is often considered to be a single label, but physiologically, preemie, newborn, toddler, grade school, teens are very different. And so if we only talk about pediatrics as one group, we're going to miss a lot of the variation in that population.
Interesting. I would have never thought about pediatrics as a minority population, but it makes sense since every single drug says, but not for children, because we didn't test that.
Yep.
Fascinating. Well, Keith, Armando, this was a really fun discussion, really enlightening. I love all the work you're doing. I appreciate you taking time to sit down with us and talk to us. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcasting application. Thanks, guys.
Thank you.
Thank you.